Good afternoon and welcome to this, the formal annual general meeting of NHS England. There are many who regard this as the highlight of Expo, indeed, if not the highlight of the entire year, and they're all here tonight. That's my colleagues who are the directors of NHS England, who I'll introduce in a moment. But let me just say how exciting this Expo has been. We have 5,900 people registered to come to Expo. 5,900 people excited about what's going on in this country, within the NHS and around the NHS, and inspired by the potential opportunities for the future. We'll hear a bit of that tonight in the panel sessions. An AGM in corporate life is a solemn and ceremonial occasion. We want that also, obviously, to be true of this event. But in order to combine a mix of Strictly and baking, we're going to have some panels. And so we will have a program in which the Chief Executive, Simon Stevens, will speak to us. We'll then have an opening panel. Then we will have Paul Baumann talking about the financial accounts. Now, the thing about Paul is that the eloquence with which he expresses the financial position of the NHS rather reminds one of what somebody once said about the music of Wagner, which is that it's not as bad as it sounds. And I always look to Paul for reassurance and for intelligence on these occasions. Before we kick off, and I'll introduce in a moment our MC, I'd like to introduce the directors of NHS England who are with us this evening. And I'll try and do this by alphabetical order so as to show no favouritism, which is, after all, the chairman's responsibility in these events. But Lord Victor Adebowale is here in the front with us. Sir John Byrne, clinical geneticist. Dame Moira Gibb, strong background in local government and in social care. Noel Gordon, Noel has not... He's just had to leave. Please do not take that as a comment, but Noel's portfolio since he joined NHS England has been nobly enhanced by becoming the chairman of NHS Digital and also the chairman of Healthcare UK. I have a few other tasks for him since he's left the room, which we will advise him of later. Michelle Mitchell is the Chief Executive of Multiple Sclerosis, and Joanne Shaw is former chair of the Audit Committee of the National Audit Office. So wonderful to be able to suborn her to the accounting protocols of NHS England. Absent tonight, unfortunately, are Wendy Becker and David Roberts, my deputy chairman, who is also chairman of Nationwide, and today is their board meeting. I would also obviously wish to introduce our executive team of board directors. They include Paul Baumann, Jane Cummings, who's the Chief Nursing Officer, and Jane has also taken on recently the interim role of being the leader of our office in London. Thank you, Jane. Ian Dodge, Director of Strategy. Sir Bruce Keogh, well known across the land, and Bruce, as I think everybody knows, has been the National Medical Director of the NHS for nearly a decade, and sadly is proposing to bring that term to an end at the end of this year. But Bruce, there will be many other occasions in which we have an opportunity to thank you, but formally today, on behalf of the board, I would like to do that. And Matthew Swindells. That then leaves only our Chief Executive, Simon Stevens, and I will like also just to record at this stage one of our executive team who has gone back to another job in Whitehall, who is Karen Wheeler, who made an enormous contribution to the work of NHS England over her time. So, without more ado, I'd like to introduce our MC for tonight, Richard Vyse of The Guardian. Richard.
Thank you very much. Oh, thank you. So, welcome to the NHS England AGM. This allows NHS staff, the organisation stakeholders, and above all, members of the public to review NHS England's plans and finances and to ask questions about its directions and work. So, as Malcolm alluded to, we're going to begin with a speech by the Chief Executive, Simon Stevens. We'll then have the first of two panels. We're calling this the Next Steps panel, and that's looking at how NHS England is working with its partners to try to deliver more responsive and more joined-up care. Paul Baumann, has already been mentioned, will then formally produce the accounts and the annual report. There'll then be a second panel with NHS clinical leaders, and then finally we will have the Q&A session for the AGM, which is your chance to question the national leadership. There'll be a panel on stage to respond to you, but also the entire team that's been introduced will be there for you. So, to begin with, Simon, may I invite you to speak?
Hey, thanks very much, Richard, and Malcolm, and everybody. Malcolm said that ceremonial and solemn is part of what this AGM is about, so that's going to be the Paul Baumann bit. Paul is going to really look back specifically at the year concluded, 16-17. I'm instead just going to very briefly single out some of the agenda that we are working on this current year, the year we're in, 17-18, because obviously our AGM kind of falls halfway through the year, so we're doubling up between us. But in doing that, I just want to put the debate we always have about the NHS in the context of what the people of this country actually think about our efforts over the course of the last year. And I think it is worth remembering the very high public esteem that the National Health Service continues to be held in. The best way of measuring this is something called the British Social Attitude Survey that goes back many decades, and what that found is that the past year that we're here to talk about, actually the net satisfaction with the National Health Service is the highest it's been in all but 3 of the past 30 years. That is a tremendous tribute, frankly, to the 1.3 million nurses, therapists, doctors, other staff working often under pretty challenging circumstances, as we will hear, right across the country. We took the opportunity as the NHS leadership in March, at the end of the year we are giving account for, to set the direction for the next couple of years. And we chose the really imaginatively titled Next Steps on the NHS 5-year forward view to set out what that needs to comprise. And given all of the pressures and all of the debates, we felt it was very important to focus on a smaller number of key national priorities that we would help contribute to driving over the course of the next 12 and 24 months. And so those 5 that we will be debating here at Expo and constitutes the work programme of many of the people here in this room are these. First, to improve A&E performance and the wider experience that patients have of using urgent and emergency care services. And I'm going to be talking tomorrow a bit about some of the pressures we can see for this coming winter and how we need to mobilise around them. The critical responsibility that we at NHS England have for primary care services, for GP services. The clear improvements you're going to hear about in the panel in a moment around cancer and mental health services, all within a difficult financial environment that Paul is going to describe, but recognising that just doing more of the same is no longer going to work, and therefore really the kind of essence of Expo is about doing things differently and better. And so accelerating local service redesign is essential for that. Let me just pick out a few of those briefly, because I will, as I say, have the opportunity to talk more tomorrow. On primary care, let's not forget that each year, including the year we're reporting on, 16-17, about 300 million times patients have visited their GP surgery over the course of the last year. That compares with about 23 million visits to A&E departments and other parts of the system. So what happens in primary care is really crucially important for the NHS as a whole. And yet, if you look back a few years, you see that we have not actually acted on that insight. If you see what has happened to the growth in GP numbers, for example, you can see that compared to the quite substantial expansion that there have been in hospital consultants, actually GP numbers have been falling. And that is why NHS England explicitly, with the BMA, with the Royal College of GPs, are now embarked on a programme to both increase investment and reform the way in which primary care services operate. And I think it's a source of modest pride that in each of the years prior to the existence of NHS England, actually GP spending was going down, and now you can see that we have put a clear kink in that curve and are in the early stages of a significant shift in the resourcing and the design of primary care services. What does that mean for the public? One of the most obvious expressions of that will be we want to make it easier for people who need a GP appointment to get one. And that experience has actually been worsening in recent years, hardly surprising given the position that I've set out. Instead, therefore, the rollout of easier booking organised on hub bases, populations 30 to 50,000, and if you run into a GP or a leader from Greater Manchester while you're here at Expo, ask about the action they have already taken. This is not a plan for the never never. This is actually happening across Greater Manchester now. It is happening across London now, and you will see it rolling out across the whole of the country over the next 18 months. We're going to hear in one of the panels, I think, about cancer and mental health services. I won't steal the thunder there, other than to say that in the case of cancer services, for example, we know that we need big infrastructure investments in radiotherapy, which along with modern cancer drugs and cancer surgery is one of the three main ways in which people with cancer get properly looked after. And it is a source of pride that we have now kicked off the biggest upgrade in radiotherapy, Linacs, that we've seen in over 15 years. And you only have to go as far as the Christie Hospital here in Manchester to see the impact of that. But that is happening right across England. On mental health services, sometimes when you're in the middle of something, you yourself don't see it. It takes the opportunity to be seen as others see you, holding a mirror up to understand what's really going on. I was struck by this headline in the New York Times at the end of July, commenting on the work now to implement the mental health task force, describing England as being in the middle of a unique national experiment, the world's most ambitious effort to treat depression, anxiety, and other common mental illnesses. And that's only the beginning of what we're about. You'll hear from Claire Murdoch and others in a moment more on that. We know that as we embark on these changes, we've got to have consistency of offer in many of these areas, but we've also got to recognise the diversity that this country represents. And so we make no apologies for the fact that we are deliberately trying to focus more on improvement and outcomes than we are on administrative structures. We make no apologies for the fact that in devising the big improvement blueprints for mental health services and for cancer services and for GP services, we did so with patients groups and with professional groups rather than by ourselves. We make no apologies for the fact that the route that Andy Burnham and colleagues are charting, John Rouse and colleagues here in Greater Manchester, will be different than the route that people in Surrey or Cornwall or other parts of the country will be choosing. Because if you're focused on outcomes and service improvement rather than administrative structures, then you want to back the energy and the continuous improvement wherever you find it. But I think if Expo means anything, it means a recognition that simply doing more of the same is increasingly unsustainable. That is offering a difficult environment for our frontline staff, and it is increasingly challenging for patients. And so the history of the NHS, as we will hear tomorrow, is a history of redesign and innovation, and Expo is all about putting fuel in that tank. We see already that where different parts of the country are redesigning services, they are not only improving the quality of care, but they are relieving the pressure on other parts of the system. And so one of the things we were particularly pleased to be able to show during the course of last year was that the vanguards, the parts of the country that have got on with integrating the way their primary and community and social care and hospital services work, those parts of the country are seeing lower rates of emergency hospitalisation, which is part of the answer to the winter pressures which rightly the whole of the National Health Service is focused on. So I hope that gives you a flavour not only of some of the energy and effort that has gone on over the course of the last year that Paul will describe more, but also the agenda that we have set ourselves for the year ahead. That's the agenda that the panels will now talk with you about, and we'll have a chance to discuss more during Q&A. Thanks very much.
Thank you very much, Simon. Can I now invite members of our first panel to come up to the stage, please? So this is our next steps panel. So Keith, Matthew and colleagues, thank you. So this is our panel, which is going to be discussing what NHS England is doing in its work with its partners and stakeholders to deliver more responsive, more joined up care. Each of our panel is going to speak for just 3 or 4 minutes, and then at the end of that, I'll be asking them some questions. So can I invite, first of all, Matthew Swindells, the National Director for Operations and Information, to say a few words. Matthew.
Thank you very much. Yes, I'm pleased to talk a little bit about what we've been doing with STPs and ACSs in the past year, because we're seeing real systems now coming together to work differently. I've had the pleasure of the last year to meet with all 44 STPs twice, and to do a series of follow-up meetings with them, and also then to go into meetings with some of the most challenged systems across the country. And what I can say is that across the past year, every single part of the country, that working together as a partnership, that coming together as a team, has been enhanced. They are all in different places. They reflect their history. There's still a range between our most advanced STPs, where they're working very closely as health systems. They're working very closely with local government. They're working very closely with the voluntary sector, and others where they're still on a journey, still building those relationships. We have places where the local authorities are in the lead, such as in Nottingham and Surrey, where the chief executive and deputy chief executives of STPs are actually leading the work. But wherever you go, we are seeing an approach developing, which is saying that there is a complexity to the challenge that the NHS faces now, that you can't work in silos to solve this. We need to see partnerships developing across acute and community and primary care, across the NHS sector and the social care sector, closer engagement with the voluntary sector, because the challenges are hard, because demand is high, because patient needs, public needs are high, and to do the system shift that we want, to get the right patients, the right care in the right place, needs teamwork. It requires a consolidated effort. So if we think, as the Royal College of GPs said, that 27% of the patients who go and see a GP could have cared for themselves. And if we think, as our studies show, that about a quarter of the patients who go to an A&E could have been treated by a GP, but our GPs are busy and full, and our hospitals are busy and full. If you don't do that work together, you can't do the shift. And we're seeing increasingly that the attitude that was expressed over a year ago by a teaching hospital chief executive in London, that they enjoyed patients who didn't really need to be in the A&E coming to A&E because they made money on every case, that is now treated as outdated and outmoded, and that is not the way that the NHS thinks anymore. So I'm very pleased that over the past year we have seen a partnership between the NHS evolve a really long way, and significant steps with local authorities, because NHS staff want to work together and want to work on a focus which is around the health of a population and the needs of individuals, and are taking advantage of the sort of freedoms and the opportunities that we're trying to give them.
Thanks very much, Matthew. Now I'd like to invite Professor Keith McNeill, the Chief Clinical Information Officer. Keith.
Thanks, Richard. There's no better way of integrating a system, joining it up, than getting the flows of information across that system right. And so through the digital agenda, the transformation that we're embedding is about getting information to the right place to the right people at the right time. Creating a learning and knowledge-based organisation where every decision we make across the NHS every day, whether it's clinical or non-clinical, is informed with really high quality evidence and information based on longitudinal analysis and savvy analysis of all that work. There's also no better way of encouraging innovation than to get information and evidence to understand how that innovation is going, where it's working, where it's not working, where we can fail fast and move on, or where we can spread at pace and scale things that are working really, really well. So some of the things that we are going to be doing into the future, we've already created the Global Digital Exemplars, which is unashamedly setting the bar at international best practice for our hospitals and mental health services to showcase what we can do better than anywhere else in the world. I was at a panel today at the National Information Board where the mental health people came together articulating what they are doing and what they need in a digital sense for their patients moving forward, and they are creating world's best practice in terms of the digital offer to mental health patients. We're doing this right across the board in terms of the way patients will interface with the NHS, so recreating an entire digital interface for patients so that they get a modern 21st century look at the NHS. They will choose to come to the NHS digitally first, taking away the burden from the front line, giving them alternatives to face-to-face consultations, and giving them a really savvy experience where they choose to do so. Right across the 2020 program, we've aligned to the 5-year forward view next steps, and we've aligned to the triple aim of healthcare so that what we deliver translates into tangible improvements for both patients and the staff that deliver healthcare to patients each and every day in everything they do.
Keith, can you just explain what you mean by the triple aim for people who may not be familiar with that expression?
So the triple aim in short is really about providing better outcomes for patients, providing them with a better experience and creating a sustainable system whereby those outcomes and that experience can be delivered. They're all interconnected and you can't do one without the other, and so our aim is to, as we've refocused and realigned the 2020 program, all the digital work that we're doing, to enable us as a system, as individuals and collectively as a system, to deliver on that triple aim.
Great, thank you. Next I'd like to invite Professor Jane Cummings, the Chief Nursing Officer. Jane.
Thank you. So when I was thinking about what I would say in how we're working in partnership, the one programme that came to mind is the one we're doing with learning disability. And that programme's been running for a couple of years now, but I think it's a really good example of how we've really looked at cross-system working. There are about 1.2 million people with learning disability in England, and about 25,000 of those are at risk of hospital admission. But that means that the vast majority are actually cared for in the community with local government, social service support or other voluntary sector support. So in order to deliver what we really wanted to deliver and want to deliver around improving care for people with learning disability, we had to do that in partnership. So we set up Transforming Care Partnerships, which were an advance of the STPs, and that was really bringing together commissioners, providers, people with learning disability and their families to really determine what that care should look like. And I think it's been tough. There's no doubt that it's a difficult and challenging programme that we're running. But what's been really interesting is looking at how with CQC, Health Education England, NHS Improvement, local government, ADAS, Children's Social Service, etc., Department of Health, we've really come together to focus on what's important. And some of the things I've learnt from that is there is always a way through, but you just have to sit and think about what's your end game. It's not about organisations, it's not about individual organisational responsibilities, about keeping in mind what the end game is and what we're really trying to deliver. And actually when you look at that, and then we've been able to overcome quite a few hurdles, quite a few obstacles to be able to deliver that. And through the cooperation that we've had, the delivery board we've had, we've been really able to shift practice, shift care. It's still, I would be lying if I said it was easy, but we have improved the care, we have closed beds, we have improved the number of people that are discharged. But we've only been able to do that through partnership working. So I think that's a really good example and one that we will continue to build on with our partners as we go through. And then the other example I thought about when I was thinking about what I was going to say was around workforce. I guess many people in the audience would think I was probably a bit mad as the CNO if I didn't mention workforce at some point when I was sitting here. But for me, actually working across the system again with Health Education England, NHS Improvement, NHS England and colleagues to really deliver what we need to do around the workforce is critical. And later, I know you'll hear from Claire in terms of mental health programme, but the mental health workforce plan was a really good example of how organisations came together to deliver and publish what was an important plan. So again, something really important that we need to continue to build on, but two really tangible examples of, I think, where we're making progress.
Great, thanks, Jane. Next is Michelle Mitchell, one of the non-executive directors of NHS England. Michelle.
Good afternoon, everybody. Simon started with a thank you to a number of the staff across the health and care system. I would want to repeat that thank you, but also add a huge thanks to the many volunteers, voluntary and community sector organisations, and also many of the families and carers and patients themselves who support each other and work tirelessly to enable people to live their best lives possible. We're incredibly lucky here in England to have an NHS that is the main reason people are proud to be British, as it says in the British Social Survey data. And at the heart of that is a deep felt commitment to bringing high quality care for today and for tomorrow. But within that commitment, I think there is an important acknowledgement that the relationship between patients, citizens, as I like to call them, and communities also has to change, because without a change of relationship, we won't go as quickly as we want to in achieving our goals of better care, better health, and a sustainable financial system. So I was particularly pleased to read in the 5-year forward view, a deeply held belief of mine, that there is the renewable energy in people and communities. And that's an important philosophy and belief, I think, that underpins the leadership of NHS England, the broader system as a whole at the moment. And I think it is important also to see that belief, that philosophy, translated into practical improvements, real improvements in people's health and well-being. So when we look at the progress that's been made, we should be extremely proud of those real differences in cancer, in mental health, in learning and disability, in a whole range of areas, and also proud that many of those major programmes have been designed and developed with citizens, with the voluntary and community sector, with a belief that together in partnership we can do much more than we can do alone. So I also want to see some of those particular initiatives around social prescribing, self-management, integrated and personalised commissioning make even quicker progress, which I'm sure they will over the forthcoming months and years. So really exciting time. We're on a journey. I think we're making good progress, but there's also a lot more to do to ensure that patients and citizens are at the heart of their care, and we truly realise the vision of personalised and person-centred care in the future.
Thanks. And of course, your views are very much informed, aren't they, for your experience of running the multiple sclerosis organisation and very much seeing that patient lens on the work?
Absolutely, but also seeing the power of people, absolutely taking responsibility and care for their own self-management of their condition.
Indeed.
And also seeing the potential of citizens and the community sector and voluntary sector in delivering in partnership much better health and care and helping support build a sustainable system.
Great, thanks, Michelle. And finally, Ian Dodge, the National Director for Strategy and Innovation. Ian.
Thank you very much. So 2 themes from me. First of all, partnership. We can't do it alone. And the second is on industrialising the changes we want to see. So how do we do stuff at scale? And what I really wanted to do in these few minutes is to just highlight some of the partnerships we have with non-NHS organisations. So if we're going to crack our growing medicines bill and avoidable emergency admissions, that means that we have to work really closely with the care home sector. We have to support pharmacies dealing with contraindicated polypharmacy there through the work of the Care Home Vanguard. If we want to try and improve the evidence base around what works, we have to get much better at working with the National Institute for Health Research and the universities to make sure that we're better at articulating what research we really need and then spreading the research of what works across the NHS. If we want to get upstream in tackling some of the future pressures on demand. We've got to work with schools and do things like replicate the Daily Mile programme that is coming out of the Morecambe Bay Vanguard, where over 50 schools are now having their kids do a mile of exercise every day. If we want to tackle mild to moderate mental health problems, or indeed some of the more moderate musculoskeletal problems, we've got to work with the job service, with DWP on our health and work trials. If we want to try and spread medtech, pharma, and digital innovations, that means working more closely with those industry partners. Michelle, you've already mentioned working with the voluntary sector. Why is it that in Tower Hamlets now they have 1,400 different voluntary sector organisations systematically connected up to the NHS through a system of social prescribing? Now is the time, surely, to begin to industrialise those proven methods. And then finally, I wanted to highlight and really reinforce Michelle's point around patients as our key partners here. So less than 30 miles away in Warrington, 148 patients were invited to take a personal budget for end-of-life care. And in that particular cohort, 83% ended up dying in their preferred place of death, as opposed to a local control group of 29%. And there was also a massive reduction in cost. So maybe part of the answer is handing power over to patients and then using our vehicles of the SDPs, the accountable care systems, and our NHS innovation architecture, the AHSNs, to help try and curate and spread best practice. Thank you.
Great, thanks very much, Ian. Now, Matthew, can I come to you first of all? So we've got roughly a fifth of the STPs are going down the accountable care system route. First of all, could you actually just try to nail what an accountable care system is? There's a lot of discussion at Expo about it. It'd be good to get your definition. And what is your sort of realistic assessment of what they can achieve over the next 2 to 3 years?
So I think first of all we should say that accountable care system is the evolved version of an STP. It's a journey that we want every part of the country to be on, not a special class of different sort of system. And it's where the system has come together and voluntarily chosen to share some of the authority from their individual organisations to take responsibility for delivering balanced finances across a system, high quality care and high quality access. So they're working together and saying, let's park our institutional interests to one side and focus on the needs of the population and what is the best healthcare we can deliver within the money that is available to us. And if that means sharing obligations around workforce, if that means sharing obligations around budgets, about not getting tied up in where the money lands as opposed to making sure that we as a system balance, then that's accountable for a population.
Now, one of the big challenges which you alluded to in your opening remarks is about trying to get people to think and work in systems rather than in organisations. And this often gets very personal, doesn't it? Because it's, you spent many years developing your own clinical practice, and suddenly your organisation is perhaps going to lose work to another part of the county or whatever. What evidence do you see that the NHS in large numbers are embracing the idea of systems working and putting their organisations and indeed their own interests second to the system? And what more needs to happen to make that the dominant culture in the NHS?
Well, as I said, Richard, we are seeing this happening in pretty well every part of the country. So I spent quite a lot of time with the most challenged health systems, and one of the remarkable things that we've seen in the last few months is the extent to which primary care, community services, hospitals, the commissioners and the providers are coming together to focus on what is the needs of a population. And if the answer is that we need to redesign out-of-hospital care, urgent access, in order to reduce pressure on the A&E department, and the consequence of that is a reduction in income to the hospital, but a net reduction in cost to the system, but better care, then people are working together to do that. And we're seeing versions of that happening across the country, places like Dorset, where the system is working closely together, in West Berkshire, where they've moved away effectively from the payment by results system to a capitated budget, to areas like Nottingham, where they're looking at how do they identify the most at-risk populations and target care around that. We're seeing that that breakthrough. You're right that there's a lot of learnt behaviour around organisations, and this is not an easy journey. And to make it go further and faster, it requires not only the bottom-up pull, which we are, I think, seeing very clearly and playing much to the wishes of the NHS, but also top down. We need to be smarter about the way in which we are supporting, the way in which we're regulating, the way in which we're inspecting, to encourage that kind of behaviour and not allow our behaviours at the centre to be pushing people back into their silos, whilst at the same time urging them to break out of their silos.
Yeah, so there's years of work ahead, isn't there, in terms of getting that context right, getting the framework that everyone's working in to encourage the right behaviours.
I'm sure there is, but then but the improvement and development of the NHS is a continuous process. Yes. There's no magic moment when you go, it's been solved. What I've been impressed by has been the way in which we found health systems have almost been grasping and saying, at last somebody has told us to focus on a population rather than focus on an institution. And we are... organisations are saying we want to be the next accountable care systems, and we have quite a challenging memorandum of understanding about what we expect them to deliver, and organisations and systems are coming together and saying we want to be next, we think we can work like that. So I think we are playing to the culture of the NHS rather than against it here.
Yeah, so people see the liberation potential of that approach. Thank you very much. Keith, can I turn to you? Digital in the NHS is a somewhat unhappy history of great ambition and great promises, and inevitably followed, it feels, by patchy progress and disappointment, and then another sort of almighty effort to try to move the thing forward. Can you say with confidence that there is now system-wide improvement happening in terms of digitising NHS?
Yes, unequivocally. You talk about, you look at it with a glass half empty, and you can certainly look at that, but you think about Connecting for Health, which delivered the most digitally advanced general practice service in the world. Delivered us what is a Rolls Royce, and is looked at around the world jealously with the spine infrastructure in terms of the way we collate the messages. Handles more messages a day than all the financial institutions put together in England. So there's an enormous amount that we have achieved, and you know, I'll say this because I'm Australian. The British have a habit of beating themselves up about really good stuff. You know, you should celebrate this. I mean, there's so much good stuff that's going on here, and we are delivering day in and day out. And if it would take me an hour to list all the stuff that's happened just in the 12 months since the WACTA review came out. The amount of stuff that is being delivered. Now, can we ever do it fast enough? No. Can we ever do it enough to keep up with the ever-changing demands of the NHS? Probably not. But we're setting up the platforms now that will enable us to start really embracing wholesale all of the great things that technology can do to underpin the transformational work that we need. We are motoring along. We've created momentum. We've got engagement right across the system from the ground up. And you know, this is going to deliver a huge transformational change over the next few years.
So the WACT review, that was the review for the government by the digital lead from the States, and Robert Wachter, really Correct. To try and ground NHS digital policy in sort of clinical reality rather than some sort of big policy document, wasn't it? Around Expo, we've got the evangelists for digital. You know, we've got some fantastic examples. You've got doctors walking around in virtual reality goggles and so forth. That's great, but clearly we need to make digital skills absolutely mainstream when people are coming out of medical school, through nursing university and so forth. What's happening to give every clinician the digital skills to become a digital entrepreneur?
Yes, that's a really good point. So one of the focus of the National Information Board, the Personalised Health and Care 2020 program, is a workforce piece, which starts in two ways. The first is that in partnership with HEE, Health Education England, we are putting together programs that go right across the workforce in the NHS, and then ultimately will go down to all of the clinical schools right across the country to start facing the issue about what they need to come out with. Now, of course, generationally, people are coming out in a very digitally savvy way. So they're already comfortable with the technology, so we're pushing it open doors there. At the other end, if you like, to put it that way, we have the Digital Academy, which will get going over the next 6 to 12 months. And that's aiming at really at a different level, where we want to complement what we're doing with the global digital exemplars and get people up to a level where they are world's best practice in terms of their ability to use technology, their ability to analyse the data that's coming in on behalf of themselves and their organisations, and also to give them transformational leadership skills that enable them to use that digital technology to really underpin the change in their organisations to deliver better care with using all the digital stuff that they have available to them.
Thanks, Keith. Jane, now you've already mentioned the fact that one of the biggest issues that's you're working day in, day out is workforce. And people are saying, you know, it's now sort of right up there now with funding in terms of what's keeping people awake at night. Now, you have a plan to increase the nursing workforce to the levels that are projected to need by 2020, things like the Nurse First programme. There's a lot of work to improve retention and also the return to practice push as well. But looking across the range of that programme, there does seem to be an awful lot of risk in all the different parts of that. How confident are you that we won't hit real serious workforce difficulties in about 3 or 4 years' time?
So I think it's fair to say that workforce is probably one of the biggest risks that we're facing. And it's not just about the nursing workforce either. I think
Indeed, yeah.
there is, you know, if you look at the total workforce issues and you look at the total gaps that we've got there, they are concerning. What I do think, though, is that everybody recognises that and that there is joined up and systematic action across all of the organisations. Yes, clearly for me there are some risks around the changes to the bursary, which we've had. The latest figures show something like a 6% reduction in the number of student nurses that have started now. So 6% less than last year, but around the same number as the year before, actually. So the drop hasn't been as big as many were predicting. And we know that universities are still planning to recruit further into this year. So I think if we can genuinely make nursing a really attractive career, despite having to pay the fees and lose the bursary, and we do that by, for example, some of the work that's going on in London around the Capital Nurse programme, where there is some guaranteed employment in London for London's graduates, that there is work through the SDPs around making sure that opportunities are there for really flexible working, which I think, and make really interesting jobs. I think some of those are really important pieces of work. NHS Improvement are leading the retention programme, and I think if you look at across the country, there's a huge amount of variation. So within organisations and within systems, there are big differences in how organisations are able to retain staff. So NHSI and NHS employers are working together and leading a really detailed programme with a specific programme for mental health, because that's a real area of risk. But a lot of that is about responding to generational differences. Yeah. Understanding that actually quite a lot of F2s don't want to go straight into training as junior doctors. They want to be able to do things differently. And we need to be much more open to understanding what the generational needs of people are. They're very different now from when I trained and qualified as a registered nurse many years ago. You know, that was a job for life and you did it and you stayed in it. Now people want flexible careers. They want to be able to take time out. They want to be able to do a portfolio approach, and we need to really to be able to respond to that. And in terms of return to practice, some of the big messages we get back from those nurses that are particularly doing return to practice is the need for flexible working opportunities, and having organisations that are prepared to provide those flexible career opportunities, whether that be through their own type of NHS bank within their own system, or through giving people really term time working hours, for example, or annualised hours, things that are really different, that reflect what people need. I think we will start to retain. Is it a risk? Yes, absolutely. But I think we have to work collectively to be able to address those risks.
I mean, the flexibility angle is difficult to overemphasise, isn't it? Because with the data about why people leave the profession, the number one wasn't pay, was it? It was about flexible and responsive working environment.
So the two things that people have come back on, particularly through the latest survey that the Nursing Midwifery Council did, was flexible working, and the other one was about having the work-life balance. And there is absolutely no doubt that despite the fact the numbers of nurses we've got are greater than there were 5 years ago, and by quite a margin, the pressures and the workload have also gone up. So being responsive to that in an organisation, whether that be a commissioning organisation, a provider organisation, or any other organisation that provides health and care for people, is really important. And we know that the lessons around culture, around enabling staff to speak up, about listening to what staff say and responding, despite the fact that our staff surveys continue to improve, and that's amazing considering how pressurised the work is. If you respond to that, you're much more likely to retain your staff, and you're much more likely to enable them to want to stay and work in that organisation, and that's really critical.
Good. Thanks, Jane. Michelle, could you just say in a couple of words, what is the role of an NHS England non-executive? So, I mean, are you representing taxpayers, patients, ministers, the Treasury? What's the role of a non-executive?
Patients and taxpayers, we're an independent body, and we bring, all of the NEDs bring an independence of thought. So we work in partnership as a board, but also we have to satisfy ourselves in terms of our own independence and give scrutiny and challenge to all that we do.
Right. Now, in terms of the role of NHS England, one of the inherent tensions in it is managing the right balance between central control and local discretion. With your sort of external lens on it, what is your judgment as to how well NHS England manages that tension, and if the balance is right for delivering all the ambitious plans we're discussing at this event?
That's a really easy question. Thank you for that. So the first point I would say, I don't know about in your household, but relationships often have tension and challenge, but the same as in organisations, you always get much further and much faster if you work in partnership. And I think that's a really important starting point. We will not be able to achieve the goals that we have set out, better care, better health, a sustainable health system, without working in partnership. I think when you look at some of the challenges that we have, we know that locally change happens at the pace of relationships, but we know that the NHS at times can be slow to innovate and scale and replicate good things. So I think that's an important tension that we have started to begin to talk about the most important questions, which are how do we improve health outcomes, how do we improve quality, how do we improve and use the resources of people and local communities. And by resources, I don't mean just what's in the budget, I mean the resources of people and patients, their families, their carers, the voluntary and community sector, and the many, many volunteers who want to make sure that the NHS remains great and is there for future generations. So those questions are important, but there are 3 areas I would want to see slightly more progress. The first one being, in certain places, we have some great ideas and plans, but sometimes it takes a long time to get going. So I would give an example in Leeds, where it took 9 years for GPs to adopt a scheme which identified carers. That scheme has now been adopted. It's bringing huge benefits to people locally, but we can't wait 9 years for that to happen again. We really can't. The second is, in a number of areas, the evidence is absolutely there and change just needs to happen. It's not about partnerships. The evidence is clear on stroke prevention, on diabetes, on emergency care. We have to work in partnership to make those changes happen now, because it's citizens and patients who feel the urgency more than anybody else with the quality of care that they're receiving and the hopes and aspirations they have to live the best lives possible. So I think broadly the balance is right. It's likely to always be a relationship which has tensions, but if we focus on the outcomes we want to achieve together and how we'll get there quicker, I'm sure those tensions can be worked through.
Thanks very much, Michelle. And finally, Ian, STPs. Now, when they were announced, they very quickly became seen as the main engine of reform in the NHS, and an awful lot of talent and energy went into developing their plans and taking them forward. Now, inevitably, after a time, that then hits choppy water when you've got to do the hard graft of implementing changes to perhaps hospital services and so forth. It feels like there's a bit of a loss of momentum with some of the STPs, and some of them are finding it quite difficult. Do you have confidence that the STP mechanism will, within sensible bounds, deliver what it's been asked to do in terms of clinical and financial sustainability?
Yes. I mean, very simply, it's yes. We do have confidence. And what I'd add is that system working is a complex thing, and the backdrop of STPs, and I've been involved in this for some years, as you know, is in actually successive policy has emphasised the autonomy of individual units, of individual hospitals, GP practices, individual CCGs. And so it is not surprising that it then takes a long time to unlock the latent desire for people to collaborate, because that's quite a change. I'd say secondly, there's then as you say, it's a hard graft of getting on and doing it. But are we delighted that STPs have high levels of ambition? Absolutely.
Right. Okay. On that positive note, can I thank our panellists? Thanks. Now we'd like to move to one of the slightly more formal parts of today's proceedings, which is to invite Paul Baumann, the NHS England Chief Financial Officer, to present the annual report and accounts. Paul.
So, thanks to Malcolm and Richard and Simon, this has become the most hyped part of this evening's activities, and indeed the highlight of the year. In reality, this slot, once again sandwiched as it is between the two panels of interesting content, feels to me like the banter that you get on the TV when there's a football match on and we get to the interval and we've got to do something to keep you from going off, making the tea, switching the channel and do all those things while the players are off, rejuvenating themselves, making a few substitutions and working out how on earth they're going to win the second half. So that's how this particular slot always feels to me. So as we transition from next steps to clinical strategies, let me introduce you to that annual staple of coffee tables around the country, the NHS England annual report, with a particular focus on, of course, the most exciting section of it, the accounts. In reality, I can't promise light entertainment or startling revelations, and I'm not going to rise to Malcolm's challenge to perform this in the style of a Wagnerian opera, as we simply don't have the 4.5 hours that it would take for me to execute on that strategy. And indeed, as Simon reminds me frequently, my job is to keep NHS finances as boring as possible, though I guess he probably means more in the real world than on the stage. Anyway, in the next few minutes, it's my job to save you the bother of reading the 50 pages of numbers in our annual report, which I'm sure you'll agree is a very welcome efficiency measure in itself. To start with the formalities, I'm pleased to report that we've again had an event-free year-end process, resulting in a clean audit opinion, albeit at the expense of a national shortage of the cakes by which the NHS accounting teams, well, mine at least, sustain themselves during the long days of April and May. We've also continued our clean run of meeting financial targets, once again safely jumping all of the technical hurdles set for us by our friends in Whitehall and exercising good stewardship of the 170 billion or so of hard-won taxpayer resources which are entrusted to the NHS. If that sounds boring, I can assure you that for the 210 organisations required to land a squadron of jumbo jets on the proverbial postage stamp, it was anything but boring, especially in what felt to me like the most challenging time for the NHS in the 10 years I've had the privilege of working in it. And then if Orla can just clear the screen for a moment, I can reveal, if you can take the text off, thank you, I can reveal that despite all of the challenges, the commissioning sector rose to a new challenge last year and delivered in full on the additional requirement to create an 800 million system reserve to cover risks across the NHS as a whole. That turned out to be a pretty accurate forecast of the amount required, and in the event it was that financial discipline which played the decisive part in compensating for the deficit in the provider sector and, crucially, securing overall financial balance across the health family, albeit by a wafer-thin margin of less than 0.1%. So I'd like to use this opportunity to pay a very sincere tribute to the CCG, CSU and NHS England teams around the country whose unstinting effort and deep professionalism made that possible. Once again, if numbers can replace words for a moment, this chart, thank you, gives you the breakdown of the 902 million underspend delivered by the commissioning sector against the key expenditure limit at the top of the previous chart. The creation of this risk reserve, which was not funded in our allocations from central government, and some unexpected pressures, particularly relating to funded nursing care costs, placed a significant strain on all CCGs and required an unprecedented level of efficiency savings. In this context, CCGs delivered over 80% of their savings plans, and the benefit to the bottom line went up from 1.5 billion in 15-16 to 2 billion in 16-17. In terms of the in-year financial position, I'm pleased to report that the majority of CCGs, 124 out of 209 to be precise, hit or exceeded the ambitious targets set for them in 16-17, including the system reserve, and a further 28 were within 1% of doing so. Our programme to improve CCG's financial resilience proved to be a timely investment, as did the board's decision back in 2015 to channel the available funding growth to those CCGs who were furthest below their target allocations. But perhaps inevitably, given the scale of the challenge, even with these measures, about a quarter of CCGs, pretty evenly spread across the regions, fell significantly short of the required financial performance. One of the major features of NHS England's own direct commissioning performance was the maintenance of the strong record of financial control established in recent years by the specialised commissioning team, who recorded an underspend of 58 million. Within that, the Cancer Drugs Fund was balanced for the first time in many years through the systematic cost control measures introduced last year and the careful prioritisation processes which we've now introduced. Within primary care, we delivered the 1% system risk reserve I mentioned earlier and started the process of securing better value on the community pharmacy contract. Critically, though, we also ensured that there was real terms growth in funding for core GP services alongside the first wave of very substantial investments in the GP Forward View. Those of you who are NHS England live stream addicts, and I know there are many of those around the country, will know that we identified the scale of the financial risks to CCGs in particular at the start of the year. One of the benefits of the integrated financial management system we run across the commissioning sector. This enabled us to intervene early, both to limit any further deterioration and to create some compensating savings in our central programmes. The resulting savings make up about half of the 902 million surplus. I do, however, need to issue the usual warning that most of these underspends relate to budgets and income only available to us in 16-17, especially as we've deliberately dialed back central programme budgets in our planning for this year onwards to maximise the resources allocated to frontline services. So we simply can't rely on this source of savings as we move into the even more challenging years ahead. We also can't move forward for some reason. Interesting. Can anyone rescue the presentation? In technical terms, I mean. Oh, there we go. Okay. Magic touch. Don't go too far away. Oh, no. Okay, all right. So our task for the next couple of years is simple to articulate, but rather trickier to deliver. The NHS needs to balance the significant and growing operational pressures facing the service with the need to invest confidently in transformational programmes focused on the key priority areas set out in the Next Steps document and which you're hearing about either side of this particular talk. And crucially, it needs to do so within a settlement which again provides limited real terms growth once population growth is taken into account. To maximise the chances of success, we've supported the NHS to break out of the usual annual cycle and draw up plans for the next 2 years. Not surprisingly, given the context I've described, this process has proved extremely challenging, but we now have balanced plans for the commissioning sector as a whole. Commissioners have also set aside 560 million of system risk reserve, with providers this year expected to play their part by creating the remainder of a total reserve of around 800 million, similar to last year. And the big question is whether it's inevitable that the reserve will again be needed to cover the planned deficit of around £500 million in the provider sector, not to mention the significant and very real risks again evident in both provider and commissioner plans, or whether we can finally start to liberate some of that capacity at least to accelerate the sort of transformational investments we've been discussing in the other parts of this event. So as we approach the halfway point of year one, that's hanging very much in the balance, but it critically depends on three things with which I'll conclude this rapid tour through the NHS finances. Firstly, as you can see up there, we need every single organisation across the country to work together with their local health economy partners to deliver at pace on the NHS's very clear plan for a step change in efficiency. Now, far from being a potential distraction from the 5-year forward view ambitions, or indeed the actions being pursued by STPs, this is an integral part of them, with much of the efficiency gain dependent on the success of the same programmes which generate the transformation in patient outcomes and experience. If you haven't yet read the purple prose of Chapter 7 of the Next Steps document, let me save you another hour or two by reminding you in more compact form of the 10 key components of the revolution in efficiency which we're orchestrating in partnership with NHS Improvement colleagues. I'm not sure, by the way, that this is the most appropriate graphic for this chart, as regrettably money doesn't grow on trees, least of all in the hard-pressed NHS, and we're all acutely aware that there isn't much low-hanging fruit left. But anyway, I had to find something to make it slightly more palatable. There are three main initiatives behind the scenes, so to speak: capturing the massive opportunities we have to unlock surplus assets and rationalise clinical support services such as pathology, eliminating duplication and waste in overheads, both within organisations and just as importantly across the wider system, and thirdly, ensuring we collect all of the income due to us. In terms of operational efficiency, we're focusing on driving up staff productivity to meet growing demand efficiently, and in particular completing the job of the purge on excessive agency usage and rates, which saved the system over 700 million last year alone. We're freeing up the thousands of much-needed beds currently occupied by patients stuck in hospital due to delays with the alternative social care and NHS support they need, and we're aiming to use the scale of the NHS to ensure we consistently use the most appropriate supplies and services and get the best prices for them. And then there are three areas of more transformational activity within the efficiency agenda. A major new programme on the left to ensure that we can prioritise and get access to the most promising drugs and devices, but critically on commercial terms which don't suck away all of our spending power from all the other services. A range of programmes to prevent illness in the first place and make sure that people receive only the most appropriate treatments in the right settings when they do get ill and need either emergency or planned treatment, with growing evidence, as Simon pointed out earlier, from our new care models, that this leads to both lower cost and better care for patients. And finally, reducing unnecessary variation in the way in which that care is delivered. And to support all of those ambitions, we've substantially increased this year the investment we're making in both the Right Care programme and the wonderfully named, my favourite acronym of all, GIRFT programme, much better if you come from the West Country as I do, but you wouldn't tell that, which of course stands for Getting It Right First Time. Now, you might be worried at this point as to whether you've got a finance director that can't count, because there are in fact 9 things on the screen, and I promised you a 10-point programme. So again, if I could just momentarily lose the text, I can introduce you to the secret 10th ingredient, which is the financial accountability and leadership discipline, which we've been working hard to build in recent years, with rapid, effective and systematic intervention where there's a risk of serious failure, and clear incentives for successful financial management, incentives, by the way, which have generally served us well in working with individual statutory organisations, but now need a very substantial overhaul to support the sort of system working that we were talking about earlier on in the evening. Delivering on that 10-point plan is, to state the obvious, a massive challenge for every health community around the country, even with the substantial programme of hands-on support which we're providing. But without it, we'll have little prospect of achieving the further step change in efficiency delivery, the graphs at the top, with the delightfully named QUIPs. Bruce, I think, has the responsibility for that particular acronym: quality, innovation, productivity, and prevention. Did I get that right? Very good, very good. QUIPs, for an accountant, means efficiency. And SIPs, of course, cost improvement programs in providers. And you can see both of those need to tick substantially up in 17-18 onwards, if we're going to deliver on the operational plans I presented a little earlier, and which I now come back to for the final two ingredients. It's already evident that even with the disciplined delivery of the efficiency programme I've just outlined, difficult choices are going to have to be made if the NHS is to live within its means and to protect the most important investments. That clearly applies to NHS England. We've taken on that challenge in the systematic prioritisation processes we've put in place for specialised commissioning, which enable us to focus our limited firepower on the most promising innovations, as you'll see in the brochure that you'll be getting tomorrow at some point. And in protecting funding for transformation in areas such as general practice and mental health, we're having to make tough decisions in other areas of potential investment. Meanwhile, at local level, the leaders of a number of particularly troubled health economies have had to come together at the beginning of this year to decide how to scale back their spending plans to live within their means. And it would take a very rosy-tinted pair of spectacles, not, I have to say, fashionable eyewear for a finance director at the best of times, to spot a scenario for this year where emerging pressures don't require similar tough choices to be made in these and other places over the course of the next 18 months. Delivering the step change in efficiency and making the right choices, of course, requires professionalism, insight, and courage. But critically, a fourth component, which frankly has become, I think, a theme of the evening, the sort of genuine cross-system collaboration which ensures that overall value for patients and taxpayers consistently trumps narrower organisational interests. Throughout the 282 pages of the not-so-lean annual report, you'll see examples of this as a key ingredient in the greatest advances described there. So as I commend the report to you, let me leave you with the final thought that it's purposeful collaboration on the very real challenges that I've outlined in the last few minutes that will give us the confidence that the NHS, heading as it is towards its 70th birthday, can deliver the next steps without breaking the bank, and therefore allow me to continue making NHS finance extremely boring. Thank you.
Many thanks, Paul, for that comprehensive canter through the NHS accounts. And if you have any questions for Paul, do please come back during the question and answer session towards the end. Can I now invite the members of our second panel, the clinical panel, to come on the platform, please? Right. So the content of the next panel is going to be looking at the 4 key national priorities for NHS England, which is cancer, mental health, urgent and emergency care, primary care, and all in the context of sustainability and transformation partnerships. So each of our contributors will be speaking for about 2 or 3 minutes again, and then they will be taking a few questions from me. And I think we're almost ready to go. Please join us. Thank you. Right, and to kick us off, of course, is Professor Sir Bruce Kehoe, the National Medical Director. Bruce, 2 or 3 minutes from you, please.
Thanks very much, Richard. I'd just like to pick up on the theme that came out of the last panel discussion, which was STPs. And I'm reminded of a conversation I must have had in the Department of Health 7 or 8 years ago, where I was sitting with some mothers of children with learning disabilities. And they said, if you can do one thing, they said, make sure that we get integrated care. And this was a recurring theme in the conversation. Then eventually I said to them, what do you mean by integrated care? And they said, not having to repeat yourself. And there won't be a single person in this room who hasn't had to repeat themselves either at the GP's practice, a hospital, or somewhere. And as I've reflected on that, it seems to me that there are 2 things that are really important to eliminate that unnecessary and frustrating and irritating repetition. The first is we need to have data transfer between our organizations. And Keith McNeil gave you some insight into that. We have our own big internal internet, if you like, within the NHS, which is very fast and takes a lot of transactions a day. We have the technological infrastructure which enables us to get there. We have still some issues to resolve. The second thing that's required to reduce that repetition is proper organizational collaboration. And by that I mean between NHS organizations, between NHS organizations and social care, between NHS organizations, social care, and the charitable sector. And there are some pretty real challenges in all of that. But what I want to do now is just to reflect a little bit on the kind of bureaucratic and technical stuff of STPs. I find myself asking, what would Bevan do if he came back now? Well, he'd take a look at the NHS and he would think of what it was like when he set it up. And at that time, the average life expectancy for men was about 65. It is now just over 80. So there's an increase of 15 years. And the people that live in that kind of 15-year gap now are quite different to the sort of people that the NHS was treating when it was at its inception, where there were no diuretics, there were no proper chemotherapy agents, there were very few proper therapies. And he would look at those people and he would see that they live on a continuous physiological spectrum. They're all people and they all have physiology. And at one end of the spectrum, people would be quite sprightly and normal. And at the other end of the spectrum, the people who needed quite a lot of pure medical and nursing care. Most people would sit right in the middle, requiring a bit of support and a bit of medication. And yet right in the middle of that, we have this massive philosophical, bureaucratic, administrative, and financial fracture, in effect, between the NHS and services delivered by local authorities. Local authorities deliver prevention, and we all know prevention's better than cure, and that's where we need to get to. They also deliver the support that people need when they get out of hospital. And so I'm sure he would say, does it not make sense just to get the people that deliver all of those services, which are so vital to the well-being of our citizens and people as they become elderly or develop long-term conditions, get them in the same room and ask, are there economies of scale? Can we join stuff up? Are there efficiencies in the face of the current kind of financial pressures that we face? And I'm quite convinced that the answer would be yes. So when I hear some of the criticisms of the STPs, I think, let's get back to the intent, because I think the intent is really good. It's about really helping people manage their own conditions, and it's about ensuring that we provide joined-up services that stop people having to repeat themselves.
Thanks very much, Bruce.
Thank you.
The element of actually people looking after their own well-being is actually quite often lost in the conversation about STPs, and it's good to remember that. Thank you. Can we now invite Claire Murdoch, National Mental Health Director. Claire.
Yeah, thank you very much. And I'd really like to start by endorsing what you say, because certainly for the success of the Mental Health Task Force, the 5-year forward view for mental health, partnership, prevention, patient self-care, patient education, working with people with lived experiences in their community, third sector and so on and so forth. These partnerships that the STPs, where they're working well, have been so instrumental in bringing together, are the cornerstone actually of great mental health. It's good mental health is located in communities and in partnership. In particular, our programme at NHS England is focusing on people who become unwell or the more serious end of mental health problems in the main, but not exclusively, and intervening more quickly, earlier, so that outcomes can be better. And it's been a great privilege, actually, to have been in my role for just over a year. And both the national mental health team, the teams in the regions, the STPs, and right across the country are hugely engaged in the narrative of the 5-year forward view for mental health. So I just want to say that I think people are really talking about what improvements they're going to deliver next. Now, let me tell you about some of them that they've already delivered. So last year, or The year that we're particularly looking back on, we saw 21,000 more children and young people as part of our aim to see 70,000 more by the end of the 5-year forward view period. That earlier intervention is pivotal in the young. The evidence base is there. And as an example of one of the things that we've achieved nationally right across the country, is the establishment of children and young people's community-facing eating disorder services. They simply didn't exist before, other than on a postcode lottery, not in many areas. And so what children and young people did then with eating disorders was be treated in a sort of generic team, ultimately in paediatric wards, coming in through A&E, and then maybe into a tier 4 bed. What happens now, nationally, is that there's much earlier intervention, working with GPs, schools and so on and so forth. And I believe, and only time will tell, that we will see a very significant change in their outcomes, quality of life, and actually the taxpayer pound. So that's a good thing. We have, however, committed also to open an additional 150 tier 4 beds. It won't be lost on people that we've had a practice of admitting some children and young people when they need a specialist bed far from home, not the majority, about 15-16%, but that's not good enough. So we will open additional tier 4 beds for a period, particularly in the south and London, to be able to admit children and young people closer to home. But in tandem, in the year ahead, we'll see more children and young people. We'll take it from 21 up to 35,000 in the community. We'll be developing crisis and respite models of care, the like of which we've not really seen before, other than in very small pockets across the country. And we are going to change, we have begun to change the model of care for children and young people. That's a real legacy for the future. Simon's already talked about the world-leading Talking Therapies programme, which is about earlier intervention for common mental health problems in primary care. It's self-referral, GP referral, and so on and so forth. And I'm so glad you put the New York Times headline up there. You'll be pleased to know that I had an email yesterday saying that it's going big in the Gulf as well, our programme, and I did read the Canadians are having a good look at what we're doing. But seriously, we are changing people's lives through this talking therapy programme. And last year, 80,000 people a month were coming new into treatment, and the majority, the overwhelming majority of those were being seen within 6 weeks, and virtually all of them within a year. Just finally, if I might, there are so many other smaller schemes that we have commenced in the year that's just concluded, and we're going to expand in the year ahead, such as better maternal mental health, yes, more mother and baby units, better care for veterans. We've now got 2/3 of the country covered with court diversion schemes. Big plans for the year ahead: workforce, ending out of area treatments by 2021, and so reducing them in the year ahead by 1/3. Care closer to home in a crisis. But huge progress made, really.
Great. Thank you very much indeed, Claire. Our next speaker is Dr. Arvind Madden, the Director of Primary Care. Arvind.
So we've already heard a little bit about why we're investing quite heavily in general practice and primary care, and it's worth just pausing and understanding the scale of that investment, 2.4 billion extra a year currently from 2021, which is a 14% real terms increase.
Arvind, can you just lift your microphone up just a fraction on your other side? Yeah. Try it. Yep, that'll do.
So I think actually we should just pause to reflect on the scale of that reversal of the investment trajectory from the days of the decade before before NHS England's inception. And that vote of confidence that it represents in general practice, and actually one might ask, why do we do that? What is the benefit of investing heavily in primary care? And actually, GPs, for example, serve 1 million patients today, and actually they will act as that point of contact that will help them through their physical, psychological, social needs. It will be where they're sharing their needs that they're not sharing with their own spouses and with their priests and with other family members, with their GPs, and actually acts as the essence of general practice acts as that human connection where there's something special about that doctor-patient relationship. But actually GPs are doing more than that. They're understanding actually how do they deal with that patient's illness within the context of their circumstances, how do they navigate them through the complexities of the healthcare system, how do they act as guardians of the taxpayer purse but actually advocates on behalf of those patients in addition, how do they act as air traffic control whilst holding the NHS checkbook in a sense. And actually for that additional investment what we need to do is reverse the previous trend, but also reverse the difficulties with morale in the service and the recruitment issues that we face with a third of GPs looking to leave in the next 5 years. And the steps that we're taking are concrete within the general practice forward view in terms of investment in infrastructure, 18% increase in IT, 750 schemes around estates completed, estates and technology, 10,000 extra staff, half of whom will be GPs or doctors working in primary care, and half of whom, and we're doing pretty well on the other targets, in relation to clinical pharmacists, investment in practice manager training, practice nursing development, physician associates, and 3,000 mental health therapists working alongside us in primary care, as well as upskilling staff within our teams. But we need to take action on the workload that GPs are facing, how we can actually start to empower patients to self-care, how we can start to reduce some of that regulatory burden that may not be efficient, how we can improve the interface with our colleagues in hospitals to reduce some of the low-value appointments, 16 million of which are happening at the moment in primary care, that could have been avoided had we had a better relationship at that interface. How we're investing in practices to stabilise them across the practice resilience programme. We have the largest primary care organisational development programme in the world in our Time for Care programme, 30 million invested over 3 years. So a number of steps around workload. But I think if we kind of zoom back out, what's important here is what is this going to feel like, this vision for primary care? What is it going to feel like for patients? How are we going to utilise these enablers of self-care around widening the skill mix, around how we use other professionals in our teams, how we use technology, how we work across groups of practices to develop scale, and actually how we align the financial drivers across primary, secondary care and other stakeholders in the system. That's what it's going to make a difference to ultimately.
Great, thank you very much. And now can I ask Professor Jonathan Benger, the National Clinical Director for Urgent Care.
Thank you. And I'm secretly pleased I've got a karaoke mic rather than a pop star headset. So, so urgent and emergency care, I guess the first thing to say is that we have a system that we can be very proud of and that the British public hugely value and rely upon in times of need. But it's a system that has become very congested and very busy. And all parts of the urgent and emergency care system continue to see substantial growth. So if we take NHS 111, for example, the number of calls has literally doubled in 3 years, from 7.5 to 15 million calls annually. Ambulance 999 calls are approaching 1 million a month, and there are 23 million visits to A&E departments last year. And the system is getting very congested, and sometimes patients are in the wrong place in that system, and they may default to a high level of care when that's not necessary. And so a lot of the work that we've been doing through the Urgent Emergency Care Review and now through the Forward View and the next steps of the Forward View is very much around making sure that we provide the right service to patients at the right time and in the right place. And key to that, of course, is getting our A&E performance back on target. The NHS government mandate is very clear on this, and we are working very hard to put the A&E performance of 95% back where it needs to be. 90% is the aim now, and in fact I'm pleased to note that in June and July we did achieve that, and we will continue to work on that over the winter. But it's not an A&E target, it's a system-wide reflection of how the system works. And so solutions to the urgent and emergency care problems are very much a system-wide and collaborative organisational responsibility in which every part of the system has their role to play. So if I can just point to a few key areas.
Just a couple if you could.
Of course, thanks. I understand. So in NHS 111, we are developing that further into a much more effective clinical advice service so that patients get the advice that they need first time from a clinician.
Within general practice, Simon's already referred to extended access to primary care, which I think is going to make a big difference over this coming winter. In the ambulance service, we've just completed a large programme to revise the ambulance service response standards and the models of response to better reflect patient needs. And that in hospitals, there is important work around front door streaming, supported by in capital investment, the development of urgent treatment centres, and flow guidance. And not forgetting mental health, very, very importantly, Core 24 standards being introduced across the country, 74 over the winter, will provide 24/7 access to specialist mental health teams, all linked together through powerful networks, which we've built around some of the specialist services such as heart attack, stroke, trauma, vascular services, and which we would continue to develop to provide system-wide support.
Great. Yes, actually, there's some really exciting developments, aren't there, in terms of bringing mental health more integrated with urgent and emergency care.
Absolutely,
Really,
it's
really
absolutely
good stuff.
essential, and it's been a neglected area, and it's really very rewarding for me as a clinician to see that coming centre stage now.
Absolutely, and some of it digital as well, which is great.
Yes.
For next, Dr. Amanda Doyle, Chief Clinical Officer for Blackpool CCG and the STP lead for Lancashire and South Cumbria.
Thank you. Lancashire and South Cumbria STP. Everybody's talked a lot about STPs, but we are the vehicle by which we will deliver all of the things that my colleagues have talked about. So our aim in Lancashire and South Cumbria is to address it's the triple aim, our key challenges. We have really poor health. We have parts of our patch with the worst life expectancy in the country. We have really high rates of chronic disease, really poor outcomes. For lots of conditions, the clinical outcomes we get are not as good as they could be if we configured ourselves better, if we delivered care in a different way. And we're not at the moment managing to do it all in the resource available. Unless we change what we do, we certainly won't do it in the resource available in 4 or 5 years' time. And so our focus is on all of those things, is on configuring the way we deliver care in such a way that outcomes improve and it continues to be affordable, and to improve health. And one of the key parts of that for me is about systematising some of the good stuff we do. I think someone mentioned before, I can't remember who it was, about children in Morecambe Bay running a mile. Well, that's great, but it'll be really great when children in Burnley run a mile and in Preston, in Blackpool. We've got some really great patches of good practice, some of our vanguards. We've got 3 vanguards on the patch delivering really innovative new models of care. We're working now to systematically roll those out across the patch, taking the learning and doing it more quickly. We've got Core 24 going online imminently, with psychiatric mental health liaison in all of our A&E departments. We've got an integrated 111 and GP out of hours service. We will have this autumn front door streaming in all of our A&E departments. And those things are because we are working collaboratively with all of the organisations on our patch. So 8 CCGs, 4 upper tier authorities, 12 district authorities, 5 NHS trusts, to work collaboratively to put aside individual organisational aims and objectives in the interest of the greater good, in the interest of the health and well-being of our community, while not forgetting we still have statutory duties to deliver around those organisations.
Lovely.
Richard
Thanks so
wants
much,
me to
Amanda.
hurry
That's great. Penultimately, can I ask Professor Sue Hill, the Chief Scientific Officer?
Thank you very much. To start, and I'll cover 5 very brief points. Firstly, as the 5-year forward view articulated, scientific and technological advances, if systematically adopted across the NHS, have the ability to fundamentally change patient outcomes and effective care delivery. The revolution in genomics, and particularly in our ability to use what is now relatively low-cost technology, coupled with our ability to bring clinical data together, is enabling us to look at all 3 billion letters in an individual genetic code. This will drive our ability in the NHS in England to both predict and prevent disease, to make a precise and more objective diagnosis much earlier on, and to deliver more targeted treatments that are personalised to individuals, such that we get a better spend from the 16.8 billion spend on medicines that we see now. The NHS has been a major contributor in the 100,000 Genomes project that's sequencing all the genetic letters in a patient's code with rare disease and their families, and also from patients with cancer. We in NHS England established 13 NHS genomic medicine centres who are really driving transformational change to ensure that participants can be recruited as part of routine care. Such that, for example, 2,500 patients per month are currently being recruited in the rare disease arm as part of routine care in the NHS each day. Not as each month, not as part of a specific clinical trial. What we're starting to see from the participation in this project is significant patient benefits, an enhanced diagnostic rate, or a fourfold increase, and a reduction in the diagnostic odyssey for some patients. Secondly, delivering more actionability for patients with cancer, and then more targeted treatments that are not necessarily about more expensive medicines. My final point then is that in building upon the legacy of the 100,000 Genomes project, the NHS England will be introducing what will be a world-leading genomic medicine service from 2018, which will see the introduction of whole genome sequencing as part of the diagnostic repertoire for the NHS, and also new ways of entering into collaborations with industry and with research and development.
Brilliant, thanks. So I think that gives just a flavour of the transformational change that is just on the horizon now, isn't it? That's going to become part of everyday clinical care, not a research project out in the clouds. Yeah, fantastic. And finally, Professor Chris Harrison, the National Clinical Director for Cancer. Chris.
Thank you. I guess the question I'm asked the most often is whether I think that the approach we're taking to cancer care is going to address effectively the difference in survival that we know there is currently between ourselves and other countries. And the reason I answer yes to that question is really because I think three things. I think we've got the right strategy, which is the strategy set out by National Task Force. We've got, secondly, a plan. And thirdly, we've got now a delivery mechanism at local level in the shape of the 16 cancer alliances and 3 vanguard areas. So we have 19 areas, 19 localities, which are a focus for leadership and coordination for cancer care in England, which we'd moved away from, and I think we'd missed something by not having that really strong focus on cancer care at local level. And moreover, those alliances, I think, are focused on the right things, the things which have caused the difference in survival. So what I mean by that is the ways of getting people into our cancer system at an early stage and doing the things which will make a difference. So what we describe as faster and earlier diagnosis, so diagnostic centres in each of the alliance areas, introducing the fit screening, thinking about the ways that we look at quality of life for cancer care, improving radiotherapy, for which we've got a national £130 million of the first tranche of money to improve radiotherapy care, and use that radiotherapy care in ways which we haven't previously been able to do. So I think we're focused on the right things, and also, and I would say this last because it's something that which, some of the other things that we're doing in cancer care don't get a lot of attention, but we are starting to measure for the first time properly quality of life. A lot of focus on, rightly, a lot of focus on mortality and survival rates from cancer, but quality of life, I think, is a vital part, and we're beginning now to be able to measure that in a longitudinal way so that we can look at that as a real outcome measure for our cancer care into the future.
Great. Thank you very much. Now, we've only got time for a couple of questions. I want to leave plenty of time for the AGM and for that sort of public accountability part of this evening's proceedings. But Bruce, can I come back to you with an Expo-related question? So what are the technologies that are going to transform clinical care? And most importantly, what does the NHS need to do now to prepare for that revolutionary change?
And there are 4 challenges to remember them. The first is mobile technology. We've seen how mobile platforms have changed our lives in almost every other walk of life. The second is artificial intelligence and the application of that to mobile technology, but we're seeing in some areas that that has got very good diagnostic capability, both in terms of clinical diagnoses, but also in terms of laboratory diagnoses. The third is genomics, and you've heard Sue explain how after a number of false dawns over the last 10 or 15 years, we've got to a point where whole genome sequencing is affordable and quick, and has utility, and that'll enable us to predict disease and to treat it with greater precision. And then the fourth is a term that I hear Simon use from time to time, general purpose technologies. Now, the trouble with them is those are technologies that are developed outside healthcare that appear to be unrelated. So, for example, I'm told, and it remains to be seen whether this is true, that changes in superconducting technology mean that handheld MRI scanners will be with us within a decade. Now, it's those kind of changes that I think will have a big impact on us. Now, the second bit of your question was, what does the NHS need to do? I think, and I may talk about this in some detail tomorrow, but we need to be prepared, particularly with mobile technology and artificial intelligence. We need to be prepared for the impact that that will have in terms of breaking down geographical boundaries, whether those are local, regional, national, or international. We need to understand the regulatory requirements to ensure that safety and quality are maintained, and we need to understand with particularly the impact that that has on the financial flows in the NHS and how we make these sorts of things affordable so that we don't get a division between privately provided stuff and NHS stuff that results in an inequality of care.
Great, thank you. Now, Arvind, there's an obvious rejoinder to what Bruce has just said for you, which is the breakdown of geographical boundaries and the introduction of mobile tech, a lot of which actually is fishing in the primary care space. Surely this is the end of list-based general practice, isn't it?
So I think the fact that actually everyone in the country has a GP with whom they can register who has a contemporaneous medical record from birth to death is actually where most countries in the world want to get to. So actually we're starting in a way that actually positions us well to use data analytics for population-based care in geographic areas, which allow us to design services that make sense for example, the 30 to 50,000 that's now talked about in the primary care networks. But you're right to say that the sort of geographically agnostic nature of how technology can be rolled out means that actually it opens up a level of disruption in the system that gives us more opportunities for choice. And I tend to think of the technology that interfaces with primary care around what is patient-facing, what is clinician to clinician or clinician to other professionals and stakeholders, and I consider that into community services, mental health, social care, etc. And what is the sort of automation of back-office process that we just need to get right around things like interoperability. And I think the opportunities that face us in around the sort of patient-facing element of that are particularly interesting in as much as we have a generation of technology natives who have seen industrial or digital revolutions in other aspects of their lives who are kind of expecting that now of us. And what does that look like in terms of self-help content, symptom checking, signposting to alternate services, online triage, online consulting with your own GP, webcamming your own doctor or clinicians in your team, and actually what does that feel like as an experience? But I think we need to position it in a way that can actually give us a patient offer that feels like a great experience, but also harnesses the efficiencies that we require of flowing large volumes of patients through these new technologies, but also maintaining it feeling quite personal to them in that journey. And that's quite a small sweet spot, but I think it's an achievable task.
Great. Can I thank the entire panel for our clinical discussion here? Thank you. Now, if Bruce and Claire can stay on the platform, and everybody else will kindly make way for Matthew to come back, and also Lord Victor Adebowale, another non-executive director. If you could join us on stage, please. So this is the part of the AGM where we invite you as members of the public, NHS stakeholders, members of NHS staff to question the NHS leadership about their work during the year and their plans for the future. So I would now like to throw it open to the audience. Yes, please. And say who you are. And the microphone's heading your way. I'll take 2 or 3 at a time.
Oh, brilliant, thank you. Hello, Jeremy Taylor from National Voices. I sadly missed most of panel 2, but panel 1 got into really interesting issues about people and communities, and Michelle Mitchell talked about the original 5-year forward view vision of changing the relationship with people and communities. And I wanted just to ask the panel where they thought the energy now needed to go. And just to put a bit of context on this, you said something that was quite a good soundbite, Richard, when you were talking about digital. You said that in the area of digital and data, the NHS had made big promises, but had then followed up disappointingly and very patchily. And it seems to me that exactly the same diagnosis could be applied to the ambitions around putting patients at the heart of the NHS, personalising, having person-centred care. The terminology varies, but basically working in partnership with people and communities. So many of us working closely with NHS England and other NHS bodies feel a sense of frustration that there hasn't been more progress, even though we've heard today some fantastic examples where there have been some really good improvements. Ian talked about the school run now being adopted in many places, personal health budgets. Jane was talking about learning disability. In some areas, there have been some big improvements in the capacity to work in partnership with the voluntary sector and local communities and patients. But it feels incredibly achingly slow and patchy. What will NHS England do next to really make a reality of the vision that's expressed in Chapter 2 of the 5-year forward view of transforming the relationship with people and communities?
Lovely. Thank you very much, Jeremy. Yes, please. Who else would like to ask a question? Nope, nobody else at the moment? Then I shall come to our panel. There's a great deal of warm words, isn't there, from the NHS about putting patients at the centre. And yet I struggle to see, when you look at the STP plans, whether those plans have been built around, from the patient outwards, as opposed to looking at the services and structures and organisations that we have. Matthew, can I come to you first with your sort of SDP hat on? Sorry. Where are the patients? Where's that transformational relationship with the patient?
So I think the thing that makes this real and not a soundbite is when you join up the question of how does the NHS sustainably provide the services to the public to what's the redesign that's necessary. I was talking at a session earlier about there was a study done which said that the value of self-care and voluntary care provided to the health system in Britain is valued at around £120 billion a year. So it's about the same size as the NHS. And unless we manage to make that step across to say, so how do we enable people to control their own health? How do we see them as full partners in their health and care? How do we start to be able to reach out to the harder to reach communities so that we're not being driven primarily by the people who are best at accessing services? Then much of what we need to do to create a sustainable NHS isn't achievable. So I think that it comes together at the hard edge of when you confront a community around the place-based challenge that they have in their STP about actually what are the health needs of your population and how you're going to do it for the money that is available. If you try and treat this as the consumers of healthcare not being full partners in that, you continue to try and run it in a sort of the traditional way, it just doesn't stack up. So the reality is that, and we begin to see it, I think it's fair to say that when you first read the SDP plans, they were they were structural to the extent they had reached out to local government, but they'd made some progress there. But it was a structural approach again. I think when you go back and look at what they're trying to do now, we're beginning to see a different culture break out.
Great. Now, Victor, with your own experience through the Turning Point organisation and what you see as a non-executive, what's your perspective on the patient role?
Well, I think we're learning, and I don't think we should be ashamed of that. I mean, I welcome Jeremy and colleagues in the voluntary sector being impatient. There should be. We need to reverse the inverse care law. The NHS, in my personal view, is becoming a movement, not just a structure. That involves a huge amount of change. So I think we're learning, and I think we should, we should keep the vision long, learn short, crack on. I've been asked, just to answer your question directly, I think it's clear to me that the NHS England board does have a focus on this. I've been asked by Malcolm, who's the chair of NHS England, to do the impossible, but I've been asked to chair a task force. There's been 2 task forces, actually. The first was around Section 13Q of the Health and Social Care Bill, which does set a reasonable bar, quite a high bar actually.
Sorry, could you explain what that is?
So Section 13Q of the Health and Social Care Act actually states, it defines in fairly clear terms what the standard of public engagement needs to be in order to change health and social care services in an area. We haven't always met it, but we're going to have to meet it unless we're going to spend a lot of time, or Simon's going to spend a lot of time in court, defending decisions. We did produce guidance, which has been used, and I've seen it being used when I went to visit places like Newark, to actually engage better with the public. But there's more to do, and in that, Malcolm has asked me to chair a continuation of that task force, of which Jeremy is a member. Thank you, Jeremy. And we had the intention behind that task force is not to reinvent the wheel, to actually learn from the work that you've done and others. And indeed, we were at a summit, a discussion last week, ably led by Helen Bevan, so that we don't reinvent the wheel and move forward. And there are three buckets that we have to fill. The first is we have to get a better and clearer terms of engagement with the voluntary sector. I think there's a general view that it's confused and needs to be clearer, clearly focused on the priorities in the 5-year forward view, but we have to have clear rules of engagement about how we engage with the voluntary sector. Secondly, we need better measures. This is a quant and quality driven business, and NHS England needs line of sight. So for the first time since forever, we will have a dashboard which will go to the NHS, so we'll see not just how well we're doing against the statutory minimum, but also how far we're doing in terms of best practice, both qualitatively and quantitatively. And the final bucket, and the most difficult to fill, is actually bringing the experience of patient citizens, a term co-produced with citizens, part of the NHS Citizens Programme, into the thinking and the strategic decision making of NHS England going forward. So I think we're ambitious. I think we're very ambitious, and if we deliver this, we'll be the first health system anywhere to do it properly. So, our intention is very clear. We just have to make sure we match the process with that intention.
Thank you. Claire and then Bruce.
Okay, thank you. Yeah, I think there are a number of practical ways where we are seeing progress, and certainly, Jeremy, organisations like your own have been phenomenally important in nudging the system toward greater participation and engagement. But just a few practical examples. So we have a very ambitious workforce strategy for mental health, and one of the elements of the workforce that we're really hoping to promote now over the next 3 or 4 years, and it's not new, but our peer support workers, fully paid, absolutely with a career structure, but people with lived experience. And my own trust, for example, employs 40 so far, and I'm seeing this across the country as I go about visiting the place. It fundamentally changes the culture and the perspective of what people's engagement in their own care will be. I think in tandem with that, we're seeing recovery colleges and expert patient education programs led by patients, delivered by patients to patients, but also delivered to staff, by patients. So we're changing the balance of power about who's learning from who. We heard in the workforce session today about a fantastic scheme where nursing associates are being mentored for the 2-year period of their development programme in one trust by a person with lived experience who's trained in mentoring that staff member. And wherever they go in the system for their training, they come back to their mentor. So I think that really helps. I think a lot of the big programs we've been designing, so the Children and Young People's Mental Health Programme nationally, have had young minds where we've been working with the youth organisation, paying them for their time and expertise, right at the very heart of determining how you use the evidence base in real life, i.e. the optimum, talking of sweet spots, is where you know there's a clinical evidence base and people really want to engage with that. So young minds have been phenomenal in our work there, and I could give other examples. And I think just finally, Bradford, they've transformed their urgent and emergency care pathway. They don't have out-of-area placements. I spent a day there not long ago, and one of the ways they did that was by deeply working with their local voluntary sector and patient groups to look at a crisis cafe, to look at other things that people said they wanted to use in a crisis. Now they don't send people out of area anymore in a crisis. They feel good about what they do. Their social workers, their nursing staff, their psychiatrists have more enjoyable jobs. And actually we're saving the taxpayer pound as well. So I think they're just some examples of where I think huge progress is being made. We'd all like it faster, but I think it's significant.
I mean, you give the strong impression, actually, that there's lessons for other parts of the NHS to learn from some of the work that's been going on in mental health. Yeah. And indeed, the cancer work that was referred to earlier, again, looking at quality of life rather than just the treatment is such an important development there. So thank you for questions. Bruce, did you just want to come in briefly?
Yeah, I think it's a kind of multi-layered question, Jeremy. So at one level, you're asking, what can NHS England do to engage with people who receive the services with the intent of actually making those services more patient-centered? And I think the difficult issue here is that it's not just NHS England's job. The NHS is a system which consists of hundreds of organisations, some of whom engage with their patients quite well and some of whom are absolutely shocking. And so it seems to me that part of the issue is we need to understand what we can do centrally to kind of set the leadership tone and what our expectations are of those organizations that aren't serving people well. And I hear, as we all do in this room, day in, day out, those kind of stories. One of the things that's kind of missing, which organizations like yours I think could help to promote, is patient pull. We don't have the same level of patient pull in our tax-funded system as other healthcare systems where people's expectations are different because they're overtly paying for it. We do pay for our system in our taxes. And then we have a set of younger people who are growing up, people in the kind of post-internet age, who have a completely different set of expectations. They ask, why can't they get their information? Why can't they book their appointments online? Why do they have to wait in places called waiting rooms? No customer-friendly organization would get away with calling a place a waiting room. That's where you go in the criminal justice system. Everywhere else has kind of reception rooms, but there's just something about the culture behind this. And it seems to me that you started your question with digital technology, but it's going to be digital technology, immediacy of information, ability to do things on your mobile phone that'll create the kind of pull that'll force organizations to make themselves more patient-friendly. And the other thing that I think we need to bear in mind is that in the younger generation there's an increasing disregard for institutions that are remote from their lives. And so I think that highlights to me the importance of understanding how we engage centrally in our strategic development, but how we ensure we have a framework that places expectations on local organizations to be patient-centric.
Thank you very much. Do we have any final questions? If not, then can I thank our panel for their excellent contributions? Can I thank the NHS board for everything that they've contributed this evening. I'd just like to thank you for coming today for this very important part of actually the NHS England annual year, the NHS England year. Do find other ways to hold your NHS England leadership to account. Malcolm, can I just invite you to say a few words close? Probably our panel to stay put for the moment. Thank you.
So it falls to me to close the AGM formally, and in doing so to offer our thanks, first of all, to Richard Vyse for acting so skillfully and professionally as our moderator this evening. I'd also really like to thank our two signers and our stenographer. I think this is an exceptional set of skills, and I just love observing without understanding the exceptional skill that they bring to this. Thirdly, to thank every member of these panels that we've had the privilege to listen to. Nobody listening to that could doubt the passion, the commitment, the intelligence and the imagination of the leadership which we're very fortunate to have within NHS England and across the piece. Next, my particular thanks to Paul, not only for his wonderful presentation, but also through Paul for his team. This doesn't come about simply by virtue of a few days' hard work. This was a lot of midnight oil that was burnt in order to produce this. And Paul, particular thanks to you, and please also to your team. I'd like then to give thanks also to the whole of our executive team, and in particular to Simon Stevens for his leadership of our executive team. Simon, thank you for all of that. And then finally to my non-executive colleagues. As Michelle mentioned, they tend to be very independent, and I would say clear-minded and strong-minded. But actually, thanks to you all, because egos do not get in the way of what we're trying to do collectively. And I'm immensely grateful for the support that I have from you. So on that uplifting note, it gives me great pleasure to thank everybody for coming tonight and to formally close this annual general meeting of NHS England. Thank you.